Welcome to the Minnesota Alliance for Ethical Healthcare webinar. I'm Lynn Varco with the Minnesota Alliance for Ethical Healthcare. Great to be with you today. The Alliance is a coalition of 90 organizations, including healthcare providers, disability advocates, mental health experts, faith communities, and veterans organizations committed to ensuring real healthcare throughout life's journey. The Alliance advocates for compassionate alternatives to the legalization of assisted suicide. Today, we're really excited to have a webinar on the value of palliative care. And before we get to that, I want to just provide a couple updates about the Alliance and how you, our members, and maybe we have some new folks on the webinar today, can get involved. We are actively working up at the legislature here. Our legislative session is ending soon, and we're working on actually two key pieces of legislation related to palliative care. One is for full funding for the Palliative Care Advisory Council, which we need your help to make sure that that gets into the final bill that will be on that subject. So you can do that by going to our website, ethicalcaremn.org, take action, and we will have a slide here up in a moment that will show you what you can do with that. And if you're not already, you can also become a member of the Minnesota Alliance for Ethical Healthcare at Ethical Care Join Us. And you see that on your slide right now. So two really important ways that you can get involved with the work that we're doing here in Minnesota. We can't do the work without our members, and we're stronger because of all the advocacy work that you do. And like I said, the legislative session is coming to an end here on Monday, so the timing of this could not be better. So today I want to talk about our webinar, The Value of Palliative Care. We are really honored to have Dr. Neil Buddensiek with Benedictine. Dr. Buddensiek will discuss why the evidence is clear that palliative care improves patient care and quality outcomes for communities. This talk will empower you to make the case for greater investment in palliative care with organizational leaders, health plans, colleagues, and community partners. I also want to add that Benedictine is an Alliance partner. They were one of our earliest partners. And so if you are part of a healthcare organization or any other organization that is working in this space, please join us at that link that we showed earlier, and we will have that available later. Dr. Neil Buddensiek serves as Chief Medical Officer for Benedictine, where he consults on medical care delivery and coordinates activities with community medical directors. He serves as the Medical Director of hospices in Minnesota, Wisconsin, and Iowa. Dr. Buddensiek is board certified in internal medicine. He holds a bachelor's degree from Gustavus Adolphus College and received his medical training at Creighton University School of Medicine and Abbott Northwestern Hospital's internal medicine residency program. So with that, I will introduce Dr. Buddensiek to take over. He's going to present for about 20 minutes or so, and then we will do questions. You can use the Q&A function at the bottom of your screen really anytime. In fact, the earlier the better. We'll make sure we get your questions in the queue. And then certainly after he is finished speaking, we'll move to questions, and then we'll wrap up by about 12:45. Dr. Buddensiek, welcome.
Well, thanks, Lynn. It's great to be here today. And let me just get my presentation fully queued up here. Thanks for that introduction. And it is great to be a member of the Minnesota Alliance for Ethical Healthcare, representing Benedictine. And me personally appreciate the opportunity to share on this topic today. It's certainly a very timely topic, as you alluded to there, Lynn. And I think we can never, at this point, number one, in the pandemic, as well as in the state of healthcare in the United States, we can never not talk enough about the value of palliative care. And there are still, unfortunately, plenty of people that really don't understand the value of palliative care. So I want to also thank the Center for Advanced palliative care, or CAPC, for some of the slides here today. And before I jump in, I just want to provide a little bit of understanding and awareness of Benedictine. Benedictine is a Catholic faith-based organization. We are sponsored by the Sisters of St. Scholastica Monastery in Duluth, Minnesota. And our mission is to witness to God's love by creating inclusive communities, supporting those we serve to live well and to live with purpose and with special concern for the underserved. And that's what we're all about: health, wellness, and choice, and that coming to life in various communities across the Midwest. Just to give you a sense also of our payers and our revenue streams, about a third is from Medicaid, about a third is from commercial or Medicare insurance, and then privately we have, and it's predominantly in our housing portfolio product, some in skilled nursing or nursing homes, but predominantly in private assisted and independent living. And then you can see our portfolio is about 50% long-term care by revenue, and then the rest being in housing services or in our skilled rehab. We have a foundation that I'm excited and honored to be a part of, and we have opportunities to give to greater benefit of supportive and palliative care initiatives, in having our spiritual care associates be able to be deployed and employed at our local Benedictine communities, and also to help improve quality of life of residents through our Making Dreams Come True, giving them opportunities to potentially be engaged in certain activities or procure certain objects or products that give them joy and fulfillment. And then also to help for any Benedictine community member resident that has had financial resources run out, to try to keep them at our Benedictine living communities through the Benedictine care. So that is Benedictine in a nutshell. Just briefly, if you haven't heard of CAPC before, the Center to Advance Palliative Care, I encourage you to check it out. As I mentioned, a few of these slides have some of their content on there today, so I want to give that credit. They've been around for well over 20 years. They've had a great amount of curriculum to help both providers and non-providers, even the public, to have better understanding what palliative care is and is not. And so check them out. They've had over 80,000 clinicians trained in the US. They're members of 18 of 20 of the top US hospitals systems as well. So, all right, well, I'm excited today to provide an overview. There certainly could go on for many hours or even a couple days. The American Hospice and Palliative Care Conference is every year in the United States, and that's well over 2 days talking about this topic. So I'm really going to give you an introduction and awareness of what palliative care is and is not. Then we'll get into a little bit of the medical literature around palliative care and what outcomes have been validated, and thus creating the value proposition for palliative care, both in acute care and ever more so in home and community-based services, whether that be in the home, in the clinic, or in a facility such as a independent assisted living or skilled nursing facility. And then help you also as a participant and viewer today to better understand indications for potentially a palliative care consultation request from you or from your physician or nurse practitioner or physician assistant. So what is palliative care? There are a few different definitions, and as Lynn alluded to, even within the statutes of Minnesota, that definition is not really aligned with the true definition of palliative care, in that it is a approach that now has validated that it does improve quality of life of both the patient and the family or loved ones and friends that are experiencing a serious illness or a life-threatening illness. But it doesn't necessarily have to be a life-threatening illness. It can be a serious illness, a chronic illness, a complex illness, and it may have a disease trajectory that's many years, compared to having a 6 months prognosis or less which is one of the eligibility criteria for enrolling in hospice. So palliative care is much more expansive. It is focused in on that prevention and relief of suffering by means of identifying as early as possible those needs that are not met, whether they're physical or non-physical types of needs, and then doing an impeccable comprehensive assessment of the pain domains, whether that's physical pain, psychological, social, spiritual, familial pain, and then treating that, coming up with a comprehensive care plan and treatment approach. So that's the World Health Organization from 2017 and their definition. CAPC distills it down a little bit more to the point of palliative care is a specialized medical care for people with serious illness. It doesn't have to deal with just terminal illness, chronic, serious, complex illness. It focuses on providing patients with relief through both pharmacologic and non-pharmacologic means. What I mean is that medicine and other non-medicines to provide relief of symptoms such as physical pain, emotional, psychological stress. The goal is to improve the quality of life of both the patient and the family, as I mentioned before, and it's appropriate at any stage and any age. So that's a nice thing to say. It's for anybody at any age, at any stage, and it can be provided alongside. It can be provided concurrently with curative care, and so that's a very important thing as well. As you can see here, this is one of many sort of infographics or schematics of how palliative care can be integrated into curative care, or otherwise known as disease-directed therapy. So on the left, you see that there is a diagnosis, and that could be a cancer diagnosis, but it certainly could be a non-cancer diagnosis. For example, someone living with congestive heart failure, someone living with emphysema, living with a stroke and its chronic deficits from that. And sometimes, and more, when access exists and there is alignment and integration with specialists that make that diagnosis. For example, let's just use cancer. Let's use pancreatic cancer, for example. And that oncologist who, if the goals of care of that patient are to explore curative care, or certainly as much of a palliative curative care as we can, that palliative care consultation may be integrated right upstream. We're trying to get that more and more upstream, but unfortunately, it can be hard because we may not have enough providers, we may not have enough palliative care bandwidth, so to speak, or there may not be funding for that. And as we'll see, still without uniform funding across all medical insurances, what you're left with as a palliative care clinician and as an interdisciplinary team, which makes up social workers, nurses, maybe a psychologist, and a chaplain, those types of interdisciplinary team members, which are hugely important or highly valuable in addition to the physician, they can't bill for their services. Only the physician can bill for their services typically. So what you're left with is some philanthropy, some subsidization from health systems to cover that. And so that, I'm getting into barriers already, but that is one of the realities that we live with as palliative care interdisciplinary teams. But you'll see that over time then, as that disease progresses, palliative care may be more and more important, may be more and more valuable for that individual person living with whatever they're living with. And yet you'll see they're at that sort of far right is a transition into hospice. And what I want to make sure that you all understand today is what palliative care is not. And it's this sort of flip of the coin type of idea. Palliative care is not hospice, but hospice does have and include many of the philosophies of palliative care. And so, as I mentioned earlier, hospice, you need to have a terminal illness with a prognosis of 6 months or less, and you have to have someone willing to enroll in hospice. But certainly palliative care is far upstream of that terminality. There may be even conditions that are not necessarily considered terminal, but they're chronic, they're serious, and they provide a certain amount of symptom burden that's trying to be relieved. So try to remember that palliative care is not hospice, but certainly hospice has integrated many of the philosophies and approaches of palliative care. Let's transition now a little bit into why does the community and when I first became a physician, as Lynn was saying, I did my internship and my residency in internal medicine at Abbott Northwestern Hospital in Minneapolis, Minnesota, and that was at that time seemingly the center of the healthcare universe. And over time, I've actually gravitated out from that center of the healthcare universe to the facilities, the nursing homes, the assisted livings, the home care environment. And that's really becoming the center of the universe. The center of the healthcare universe is going to be, if it isn't already, your home. Your home. And so why does community-based palliative care need to have that value, have that ability to be given and deployed and experienced? Well, what we know is that there's a small portion of the US population that accounts for a large share of healthcare spending each year. The top 1% account for 21% of the healthcare spending and utilization and cost. The top 5% of people account for 49% of the healthcare utilization and cost every year. And interestingly enough, and not that surprising, people that are greater than or 55 years of age account for 56% of healthcare spending, while those that are less than 35 account for about 21% spending. Now, the interesting thing also is that even though those that are greater than 55 or equal to 55 utilize 56% of the healthcare spending, they're only 30% of the population. And vice versa, people that are less than 35 that account for only 21% of healthcare utilization make up 45% of the population. And so what you can see here is that it's the common principles that we live with. You know, the top 1%, the top 5% oftentimes has the need or the unmet need for the greatest amount of the healthcare utilization and resources. And as we age, and we're all aging, but we know that over the next probably 25 to 30 years, the baby boomer population is going to expand. It's adding 10,000 new members every day. And we have a great challenge to be able to even serve them based on where we're at in the healthcare industry and as a provider that, you know, is either in training or is aspiring to be in training, or that is in their early career or mid-career. And many of us, as we all know, are trying to get through, to navigate through, to manage through this pandemic still as well. And some people have retired and retired early. Why else do we need palliative care in the community? Well, there's strong evidence that palliative care improves quality of life, patient and family satisfaction. Certainly providers of palliative care feel much more fulfilled that they're giving meaningful care. And there are certainly avoidable emergency department reductions, avoidable hospitalizations or inpatient hospitalization reductions, and that then leads to cost reductions. There are also very few strategies in healthcare that simultaneously improve quality of life and reduce spending. So there is a really strong and developing, well over 20 years plus, of palliative care literature out there now that validates that this is of great value. A couple other CAPC slides here. As I mentioned, we have studies that would suggest that there's reduction in symptom distress or symptom burden. What I mean by that, various types of symptoms, whether they're physical or non-physical. Physical could be, air hungry, could be pain, it could be nausea, a multitude of different physical symptoms, and then the non-physical, but the psychological, the social, emotional, the spiritual symptoms as well. So there is a reduction in symptom burden that's been validated in the literature, improvement in the experience of the person receiving the palliative care, and that 93% would recommend it to others. Also looking at improvement in costs, specifically the literature does validate that there are avoidable reductions in spending and utilization in all aspects of the care continuum. In the inpatient or hospitalization side, there has been 48% reductions in avoidable readmissions, which translates into 28% less cost per day. In the outpatient or sort of residential or home environment, 50% reduction in admissions to the hospital and 35% reduction in emergency department visits. In the skilled nursing or long-term care space, a 43% reduction in avoidable ED visits and hospitalizations. And then overall in this whole home-based care portfolio or sort of bag, we have a 36% reduction in total cost. I mean, a third less cost. That's remarkable. That is a huge value to the healthcare system, and even more so to the person living with serious chronic, complex illness and their family, and the providers that are on the receiving end of having to support these people. This is to look at also the quality of care scores across the board, reduction in all-cause rehospitalizations. It's been looked at in the Medicare ACO populations, the MA plans or other commercial health plans, and in Medicaid plans. Also, relative resource use reduction or total cost of care, as I mentioned, has been reduced in all of those type of insurance plans. And experience has been very positive with this. And I think part of the reason that experience is so much of a deliverable here is because palliative care, good palliative care, takes time. It takes time, and it takes expertise as well, and it takes an interdisciplinary team so that we don't have blind spots, that we don't have gaps in our fund of knowledge or in our appreciation for the human being and their role in their own life journey, as well as the role that they play in their family and with their friends. And so that really can deliver significant heightened experience for that patient. Briefly, in the literature, in the niche that I work in, more in the post-acute care, long-term care, skilled nursing facility, back in 2013, there was a study that was titled Palliative Care for Long-Term Care Residents, Effect on Clinical Outcomes. And what they found in a cohort of skilled nursing facility residents was that there was reductions in depression scores and reduction in avoidable emergency department visits for those that had a palliative care consultation experience. Wasn't significant statistically, but was a trend towards, as you'll see, there are many different other improvements. We like to reduce delirium or changes in wakefulness and cognition and attentiveness. We also like to reduce falls, pressure injuries, and symptom burden. Also reductions in weight, so not as much weight loss as one would have expected for particular types of chronic conditions. Reductions in what we call polypharmacy, or reductions in the number of medicines that a person is taking, which is sometimes good because there are a lot of drug-drug interactions and adverse effects that can happen in people that are on a lot of medications that are prescribed, as well as some that are interacting with over-the-counter medications. And at that time in this study, there was not a significant difference, but a trend towards reduced hospitalizations. In another one in 2013, geriatric palliative care in the long-term care settings with a focus on nursing homes. The evidence that an open conversation, again, that takes time, needs to be done skillfully, but that's what palliative care can add, and that value and that expertise is the facilitation of a conversation between the resident or the patient and their family and the medical provider. And what it found was that there was increased comfort at end of life, both for resident or patient and family. So reduced anxiety, reduced potential, post-traumatic stress from having to make decisions that they may not have known were actually what their loved one wanted. That's why advanced care planning facilitated conversations are so powerful. When you have the patient and their healthcare surrogate decision maker together and having a conversation, then that surrogate decision maker, when it's time for them to act, they are not acting based on their own wishes, but they know what the wishes of their loved one are, and they're enacting those wishes. So it's not their own wishes, it's the wishes of the loved one that appointed them to make decisions for them. Reduced hospitalizations, increased likelihood that residents and families have their preferences identified or solicited, they're documented, and they're archived, and they're honored. Also in that study, fewer rehospitalizations, thus lower cost of healthcare, significant increase in pain assessments and non-drug pain treatments. Residents were significantly more likely to have preferences for various end-of-life therapies discussed and documented, and that their goals of care were coordinate rather than discordant with the actual care that they received. Nothing better than having your wishes honored and you actually receive the care that you wanted, as compared to care discordant or goal discordant care, which is, these are my wishes and yet I got something completely different. And usually it's more intense types of treatments or therapies that many people don't want, but maybe the healthcare system, the healthcare providers don't know that yet, or even their power of attorney for healthcare doesn't know that. Again, great ratings from residents and their families. More recently, 2020, there was a study on the association and of receipt of palliative care interventions with healthcare use, quality of life, and symptom burden among adults with chronic non-cancer illness. This is focusing on non-cancer illness. And again, reduced ED visits, rehospitalizations, lower symptom burden, and more advanced care planning conversations. And one other one specifically that was very explicit in the percent reduction was this one: association between palliative care and healthcare outcomes among adults with terminal non-cancer illness, a population-based matched cohort. We also saw not only reduction in ED visits and hospitalizations, but fewer intensive care unit visit stays. And that's by reducing the number of burdensome interventions that particular patient desired. Increase the odds of not dying in the hospital, but rather dying at home, or at least dying outside the hospital and potentially a skilled nursing facility. And people living with cognitive impairment, or those that are deeply forgetful, having dementia, had an increased odds of dying at home rather than in the hospital. So just my last couple slides here, and I'd love to have some Q&A for anybody that's in the audience today. Certainly any person that's facing a life-limiting disease or condition would certainly qualify for a palliative care consultation. Any person that doesn't have a life-limiting disease or condition, but has serious illness, complex illness, would again qualify for a palliative care consultation. Anybody that is in a restorative care program, and those are usually given in skilled nursing facilities or nursing homes, and they have no likelihood of getting substantially better. That means that they have serious illness, they have chronic disease, they have complex disease that's potentially not allowing them to have as much resilience functionally. Those are certainly people eligible for a palliative care consultation. And anybody that's really experiencing debilitating pain affecting their quality of life. Certainly pain specialists are possible consultant referrals as well, but certainly palliative care looks at the whole person, body, mind, and spirit. These are diseases and syndromes. Obviously, these are many complex, chronic, serious illness types of conditions, including ALS, chronic liver disease, someone that's had a hip fracture in their frail elderly, certainly could benefit from a palliative care consultation. We know that people that have had osteoporotic or fragility fractures from a fall, a low velocity, or just a fall, that they are potentially up to 50% at risk of dying in the next year. So, and then people that have very difficult to manage symptoms, and certainly some of these come into play, especially in the acute care hospital stay. And it's more and more that people can access palliative care in the hospital, but we certainly would love to go even further upstream and meet them where they are with their disease burden, their symptom burden in their home, in the clinic, in a facility. So I'll leave you with Patch Adams, as some of you may have remembered. If you've never watched the movie Patch Adams, I encourage you to do that. But Patch Adams is still alive. He is a physician. He's an American. He's a comedian. He's a social activist. He's a clown, an author. He developed Gesundheit Institute back in 1971. And he collaborates to promote alternative healthcare models that are not funded by insurance policies. So this is a quote from Patch Adams. You treat a disease, you win, you lose. But when you treat a person, I guarantee you, you will win no matter what the outcome. A couple other quotes from leaders in palliative care. Palliative care is the answer to engage with the human beings to change the journey that we face and to change it for the better. Dr. Timothy Uhrig. And Dr. Diane Meyer, the director of the Center to Advance Palliative Care, says what modern medicine needs is to have us catch up with the technology. And certainly technology can get ahead of us and cause some further dilemmas and some ethical dilemmas. So with that, I will just also plug and say that I'm delighted to be a partner with and Benedictine to be a partner with the Minnesota Alliance for Ethical Healthcare. I'm very supportive of certainly redefining palliative care in the state statute through those revisions of SF 2912. And also am very supportive of fully funding the Palliative Care Advisory Council. We can't do enough. We need to continue to do more to fund and to support and to get more and more knowledge out there and data about what the state of palliative care is in Minnesota. And also a very strong supporter of opposing the end-of-life option, HF 1358. So with that, I will stop and would welcome any questions.
Thank you, Dr. Buddensiek, for that insightful presentation about intervention of care that not necessarily all of us are aware of and know how to apply. And certainly highlighting, as you did in your last slide, the important policy work that the Alliance is doing to provide what we call equality of care to everyone at all stages of life so that they are getting the best care possible. And that's one of the reasons that we, like you said, oppose legalization of assisted suicide. And that's the first question, is that many on the other side who support legalization of assisted suicide say we need it because there are innumerable cases of suffering, horrible suffering at end of life. And as we've done our research and looked at the data, it just doesn't back that up. And certainly I think some of the studies that you and I have discussed would concur with that. So do you want to talk a little bit more about the importance of pain management and how that can help end-of-life care in terms of alleviating suffering so that we can get back to talking about equality of care instead of providing this off-ramp of assisted suicide when we really don't need it?
Sure, thanks for the question. I think the first thing I will say is certainly the palliative care literature is very transparent and honest that as a provider, as a clinician, as a physician that has had some palliative care training, but there's certainly plenty of physicians that have had no palliative care training. And certainly that's not only physicians, but nurses or nursing assistants. What is this? And there's under identification, there's under assessment of pain still this day and age, and there's under treatment of pain as well. And that's both, physical. And if physical pain is being optimized and yet there's still some kind of pain, we need to look further into the psychological, the social, the familial, the spiritual, because we know that can heighten pain or cause pain despite significant amounts of medication. In my experience, so first of all, we need to be better still about identifying, assessing, and treating pain. If we do that, and if we do that with a palliative care approach, and even with palliative care consultation and experts in this, really it should be rare, very rare, that we have as humans any uncontrolled suffering, whether that be physical or not physical. Certainly there are rare occasions, though, and I've experienced this as a hospice medical director, that we need to contemplate palliative sedation. Now, what is palliative sedation? Palliative sedation is not to just give people large amounts of drugs and to kill them. That's physician or provider assisted suicide. But it's rather to provide mild or moderate amounts of sedation through various types of medications that we may very well not use at that degree of dosing or frequency or of monitoring frequency. And again, it takes time. It takes expertise. It takes, if the physician can't be there at the bedside, need to have the nurse to be there, to be accompanying, to be with that patient and their family, so that we can adjust medications literally every 20 to 30 minutes to get them to a point of comfort. And that's where, mild palliative sedation or moderate palliative sedation certainly can be, I believe, ethical, and certainly can be of great use in those rare cases where, unremitting suffering continues to happen.
And again, the primary purpose of that pain management regimen is to alleviate suffering. It's not to hasten death, just as you encapsulated with your response. As you talked about earlier in your presentation, what are some of the other biggest or bigger misperceptions about palliative care?
Well, I think the biggest ones remain that somehow palliative care is synonymous with hospice care. And as I've mentioned, it's not. Palliative care can go along, the entire disease trajectory, from initial diagnosis to living chronically with complex, serious illness, and even at the end of life. Now, palliative care can be a substitute if for some reason the family, the healthcare decision maker, or the patient does not want to enroll in hospice. It's not the same. As I mentioned, palliative care is not hospice, but certainly palliative care can be there even at the end of life. If for some reason, for whatever reason, and sometimes there's a stigma or there's a bad experience of someone that was in the family with hospice, palliative care can certainly accompany those people at the end of life as well with symptom management. But otherwise, I think, depending on which region of the country you're in, more and more this concept of palliative care is really supportive in palliative care. Actually, some institutions have rebranded themselves as a supportive and palliative care type of, service, and making it more normative, that it actually, if we're doing our job and if health policy is doing their job and we're all working together and aligned, it should become a normative thing. It should be something that's actually demanded and requested when you're diagnosed with a serious or life-limiting illness, because it actually improves your quality of life. It can improve the longevity of your life. It can improve the comfort. And you may very well have to spend less time in an emergency room or the hospital. So I think when it becomes normative, and we actually demand it at our first oncology appointment, or our first cardiology appointment, or our first lung specialist appointment, because we're diagnosed with serious or life-limiting illness, that's when we've come to that great moment in Minnesota.
Going back for a moment to that nexus between terminal disease management and looking at the choices you want to make to navigate that. So again, supporters of physician-assisted suicide rely on that suffering argument that I mentioned earlier. But the data, especially from Oregon, which we've had for a very long time, indicates that the number one reason that people choose assisted suicide is fear of being a burden to others. And so that's why I was really heartened by your presentation that said palliative care is not only for the patient, but the family. So do you want to talk about maybe that spiritual dimension, the cultural dimension of how you work both with patients and families to navigate those non-medical issues, which in our view at the Alliance contribute to this throwaway culture in some sense, that when somebody is disabled, which we will all be eventually at the end of our lives, that somehow they have less value and need to be treated differently. And so I think if we can address some of those other issues, that might help redefine socially how we talk about and access palliative care?
No, it's a great question. Certainly the value of palliative care is in its interdisciplinary type of structure. It's coordinated interdisciplinary type of structure. And certainly the physician, the nurse practitioner potentially are the point, but they're more the point for helping to facilitate, those serious illness conversations, helping to optimize symptom management. And when you get into the other valuable team members, such as the spiritual care team member of the team, they can focus in on, the spiritual, the religious, the existential aspects of suffering, helping the patient and her family understand, make sense of the meaning in the suffering. Certainly trying to identify and search for the dignity despite and in spite of the suffering, and even helping to bring reconciliation and forgiveness amongst family members, friends, maybe people that they haven't been in touch with for many years. And I see that in hospice as well. I mean, the interdisciplinary team in hospice involves a chaplain or spiritual care as well. Also, the value of the social worker in helping both the patient and family be able to help them to support the decision making that they have to sometimes wrestle with, what is truly aligned with their preferences, their values, their goals of life, and helping them to have strength and coping strategies for stress management, and then also providing just various resources that might be needed for stress management or their goals of care. So I think we look at that as, it has to be the interdisciplinary team, and that is hugely powerful and impactful. And, it's really the secret sauce. And yet, insurers don't cover and fund all of the interdisciplinary team members. They look at it as still a fee for service that the physician bills. So I think we have to certainly reform and transform that.
We have time for one more question. We have a couple of minutes left. And this question touches on something that you discussed in your presentation about training of doctors and other providers in this area. Certainly, I think from a layman's perspective, we maybe think that there's kind of palliative care as a one size fits all, or there's just sort of one area of it. But do you want to talk a little bit about what you think is the biggest training need within palliative care? Is it disease specific? Is it within a certain practice area? Where do you see the greatest need for improvement in this area of palliative care for training of doctors and others who are involved in this work?
Yeah, I mean, I see three potential paths. I think what we know, unfortunately, is that there aren't enough palliative care providers to go around. And I was just looking back at a study from 2019, and they had one palliative care provider or physician would be taking care of over 808 eligible patients. So that's not just, patients walking in with a cold or, with a skin infection or, a toothache. These people have serious, complex chronic illness. And it's only going to get more challenging. There's a prediction that there's going to be this valley, this nadir of a workforce gap, where you're going to have one physician taking care of upwards of 1,300 patients at any given time that are eligible for palliative care. So I think we need to focus in on the reality that there aren't enough physicians to go around right now. There's certainly not also enough advanced practice nurses or social workers or chaplains that are really want to be in this niche, this expertise. And so then where do we train them? Where do we actually get that value harnessed? Well, you can do it by going upstream into the medical schools, and you have in the curriculum, every single medical student in training gets some curriculum in palliative care. Okay. And that is not universal by any means. I mean, that is very uncommon. So when you're talking about, what treatment for high blood pressure, what treatment for, diabetes, I mean, there should be a whole unit weave in palliative care into all those disease categories. So that's one great opportunity if it's done right and it's funded appropriately. Right now, and since 2019, there's been this legislation at the federal level called PCHETA, which stands for the Palliative Care and Hospice Education and Training Act. It was passed by the House twice in 2019. It's been stalled in the Senate, although there was bipartisan support. And we're still hoping to have that. Many societies of palliative care and hospice and geriatrics are really trying to get that passed and advocate at the Hill this year still, but the pandemic sort of short-circuited that for a period of time. But having more training opportunities and spots for both physicians that want to go into palliative care as a field of study, of research, and also practice, and also advanced practice nurses. That's another area. The third area, which is even a little bit more out there, but every year now in Minnesota, or since I relicensed in Minnesota, I had to take a 2-hour course on opioid management. Opioid management. I mean, certainly there could be the opportunity, although I don't know if there's been a lot of discussion about this, of having actually a certain amount of curriculum time based in palliative care, just core palliative care principles, that every physician across the board that has a medical license, whether you're an ER doctor or a surgeon or an oncologist or an internal medicine doctor or family practitioner, could be held accountable to doing to keep their license. So, I mean, I think there's upstream as far as training the next generation, which is going to take time, to the current need, but it's still going to take potentially 5 to 10 years to get there. And then also just anybody and everybody that can learn about palliative care should be trying to do it now, because there's not enough of us to go around. And everybody can do some amount of palliative care, even in their general specialty or their subspecialty. So, long answer to your question.
Well, a fitting end to a really interesting discussion, Dr. Buddensiek. We're grateful for your talk today. We're grateful for Benedictine, their involvement with the Alliance, and just want to put up our slide about how to take next steps with the Alliance. As I said earlier, the legislative session is wrapping up, and you can go to ethicalcaremn.org, as our slide says there, that second one on the second step on the bottom, /take action. And there we have several legislative outreach initiatives that you can be in contact with legislators by a touch of the button. And again, for all of those that are new with us on the call, or if you want to share this with others in your network and join our efforts to ensure real care throughout life's journey, you can go to ethicalcare.org/join us, and you will be linked into our regular emails and all of our great events like this. Thanks so much for joining our webinar. It will be recorded and will be on our website shortly. Thank you so much.